Okay, well, thanks to Mohammed and Llewellyn for inviting me to this very prestigious webinar. It is just past midnight in Calcutta. That's not a problem. The problem is that I have spent my last week with an oxygen saturation between 88 and 92%, not because I got COVID, but because I was spending my time walking at an altitude of 18,000 feet in the Karakoram Himalayas. But and I've just returned a couple of hours ago, so if I sound disorientated, it'll be the effect of having a sudden rise in my oxygen saturation. I will not say very much about open spinal dysraphism, because speaking after Graham Figan is a bit like trying to deliver the 11th commandment from behind the burning bush. I will stick to my remit of talking about closed spinal dysraphism. And as I have been instructed to try and do it within 20 minutes, I'm going to try and keep to time and go through this a little fast. Before I start, I need to acknowledge the contribution that two individuals have made to shaping my understanding of this subject. And this is a unique opportunity when I had an opportunity to dine with both of them. One is Professor Michel Gérard from Paris, and a lot of the concepts of closed spinal dysraphism I'm going to share with you is based on what we have put together as a new classification, which we do hope will be published soon. And of course, the other man who has contributed immensely to our understanding of spinal dysraphism and who has actually seen this presentation and suggested changes to it, Professor Dakling Pang, and this was a unique opportunity when I had an opportunity to entertain both of them to dinner in Calcutta. So we have actually the first publication on spina bifida or spinal dysraphism by the same man who was made famous by the Rembrandt painting in the anatomy lesson, the famous Dr. Tulp. And a lot has happened since then. Why do we call this closed dysraphism? And what is closed in closed dysraphism? And the answer is, what is closed is this. What is closed is that the surface ectoderm, which is there, gives rise to these neural folds, which go up like that, join together, and then this neural tube separates from this cutaneous ectoderm, and that's what is closed. So what is closed is, in effect, the skin. And if you really look at these newborns with lumps on their back, you can clearly see that the fundamental difference between this one and the others is that this child has an open neural tube defect, which means that there is no skin cover, whereas all of the others, which go by various names, this is the open neural tube defect, this is a lipoma, this is an LDM, this is the neuroenteric cyst, and this is the double dysraphism. And the fundamental difference is, therefore, what is closed is that this dysraphic condition in all these, apart from this one up on the top left-hand corner, have skin which is closed. So what is closed is effectively you have normal skin cover. And I use the word normal skin because you can have abnormal skin, which is not the result of normal cutaneous ectoderm. So what's the fundamental difference between open and occult dysraphism? Well, open dysraphism is a CNS malformation, whereas occult dysraphism is a local regional malformation, which is genetic and, very importantly, is folic acid independent, unlike the open dysraphism, which is folic acid dependent, as you've just heard so eloquently from Graham. And of course, the open spinal dysraphism can produce myelodysplasia, The occult spinal dysraphism can manifest by producing compression, tethering, trauma, and myelodysplasia. And in our perspective, to try and understand the different types of closed spinal dysraphism or spinal dysraphism in general, one needs to go back and look at the development of the spinal cord. And the spinal cord develops through three basic processes: gastrulation, which is the formation of the primary germ cell layers. And what happens in gastrulation, of course, is that you have the epiblast and the hypoblast, and at the primitive streak, you have the hypoblast change into the definitive endoderm. Then there is the formation of the intraembryonic mesoderm, as we have an epithelial to mesenchymal transition, and we get the development of a three-layered embryo. This process, of course, is what is called gastrulation and forms the first step in the development of the spinal cord. The second stage, of course, is the neural tube closure. And we've heard a little bit about that already from Graham. But fundamentally, what happens in the neural tube closure is that after gastrulation, which I just told you, you have this epithelial to mesenchymal transition to form gastrulation. After gastrulation, the neural tube forms by a process called primary neurulation, which means, as I showed you in the cartoon a short while ago, the neural folds rise up, join each other, form a tube. This is called primary neurulation. And then there is separation of this neural tube from the cutaneous ectoderm by a process which is called disjunction. So the neural tube closure occurs in two steps: the neural tube formation, primary neurulation, and separation of the neural tube from the cutaneous ectoderm, a process called disjunction. And finally, the process of secondary neurulation occurs, where the chordal cell mass develops a canal which joins the bottom of the primary neural tube and forms the terminal spinal cord, the conus, the chorda equina, and the phylum, like so. So you have gastrulation to establish the three germ cell layers, primary neurulation to form the neural tube, disjunction where the neural tube separates from the cutaneous ectoderm, and secondary neurulation where the terminal spinal cord is formed. And if you can think of the anatomy like this, it is much easier to try and understand what can go wrong. Let us think about the problems. The problems of nomenclature in closed dysraphism, as indeed in open dysraphisms, is that we've constantly been changing the goalpost. This is a condition that 15 years ago we would call a dorsal meningocele. Today we call it an LDM. This is a condition that we would call a meningomyelocele. Today we call it a terminal myelocystocele. So really, how do we understand all this complex nomenclature? And I think one of the key is from the embryologists. Although you will have to appreciate that most of our knowledge about the development of the spinal cord comes from cheek embryos, and indeed even worse from the Drosophila, and the highest we've reached is the rat, to try and understand the development of the spinal cord. And I really love this article published in Charles Nervous System years ago, which says, pathogenesis of diastomatomyelia. Can a surgical model in a cheek embryo gives clues about the human malformation? And I think the answer today is still probably not. Let's see what can go wrong. The first, what can go wrong with gastrulation, which you will remember is the formation of the three-layered mesoderm. Hence, the defects of gastrulation are generally ventrally placed. All germ cell layers are involved, and therefore there is skeletal anomalies in association with neural defects. And one of the problems of gastrulation, which produces a closed dysraphic state, is the neuroenteric cyst, which means there is persistence of the neuroenteric canal. It is worth trying to remember just one piece of embryological anatomy, and that is the neuroenteric canal, which communicates the yolk sac with the amniotic cavity, moves as it goes from cranial to chordal, moves from ventral to dorsal. What that means is if you get a neuroenteric cyst in the cervico-dorsal junction or the cervical spine, the neuroenteric cyst will be ventral to the spinal cord. Whereas if you get it in the dorsal-lumbar junction, the neuroenteric cyst has to be dorsal to the spinal cord by virtue of the direction of the neuroenteric canal. Okay, so what do you do with neuroenteric cysts once you've diagnosed them? Remember, they can have bony abnormalities. They can occur anywhere along the path of the neuroenteric canal. And the treatment is to remove the cyst and to untether the spinal cord. Much easier said than done. This is a girl that was operated 3 times for this neuroenteric cyst, came to us for the 4th operation. And when she came, she was 20 years old, an adult. It was 2010. She was in the 3rd trimester of pregnancy. She came with spastic quadriparesis, ended up with a respiratory problem. You can see this neuroenteric cyst has completely obliterated the spinal cord. She's already had 3 posterior surgeries done. And I just wondered, because she'd now become an adult, what could do. I had not been responsible for any of the first 3 surgeries. And we did something audacious, which we'd never done before. We went in from the front, took out a vertebral body, opened the dura, found the neuroenteric cyst, shelled it out, and then reconstructed her spine. That was the immediate post-op MRI and a 5-year follow-up. And indeed, now we have more than that. She's never had a recurrence. The other problem of gastrulation is the so-called split cord malformation, splitting of the notochord. And what happens is, because of the splitting of the notochord, there is induction of 2 neural plates, there is duplication of the spinal cord, and this is one of the first 4 paintings we have of a young boy with a tail, almost certainly a sign of a split cord malformation. We know that this has been classified by Professor Pang into a type 1 and type 2, depending on whether there is a single or 2 dural tubes, with the type 1s normally having a bony spur, the type 2 having a fibrous or a cartilaginous spur between the 2 spinal cords. But the basic embryological basis of this classification is simply this, that joining the neuroectoderm to this endoderm is this so-called endomesenchymal tract, which gradually regresses with time. And if you have an endomesenchymal tract, which is quite big and persistent, when the cells from the meninx primitiva, which forms the dura, comes close to encircle the 2 spinal cords, encounters this endomesenchymal tract, then 2 separate dural tubes are formed. Whereas if this endomesenchymal tract has regressed by the time the cells of the meninx primitiva come to encircle the 2 neural tubes, you get 1 dural sac. So the type 1 and the type 2 split cord malformations is basically dependent on when embryologically the cells of the meninx primitiva came to embrace the 2 hemicords. Again, because it's a disorder of gastrulation, it is often associated with skeletal anomalies, like the 6-year-old with scoliosis who presented to us, the Cobb's angle being 70 degrees. Of course, we untethered the cord first. And then, because we do not send our patients to orthopedic surgeons, with the pediatric patients, we fix the spine ourselves. So this is what we ended up with. And of course, split cord malformation, untethering, which means we cut the phylum as well, and then waited and then fixed the spine. With the split cord malformation type 2, these are often much more difficult to do. These are the ones that we would not recommend prophylactic surgery for, unlike the split cord malformations type 1. And here the tethering element may be just a little bit of fibrous sheath attached to the dura and sometimes a septum like that. So the problems of gastrulation cause two major closed dysraphic states. One is the neuroenteric cysts and abnormalities of the neuroenteric canal. The second is the split cord malformations type 1 and type 2. Disorders of primary neurulation, I will not talk about because you've already heard about that from Graham Fegan. These are the ones that produce the so-called neural tube defects. What about problems of disjunction? Disjunction, you will recall, is the embryological separation of the neural tube from the cutaneous ectoderm. And two things can happen. The separation may be incomplete, so there is a connection between the cutaneous ectoderm and the neuroectoderm, or the separation may be premature, which means before the neural tube has closed, it decides to separate from the cutaneous ectoderm. And what happens in each case? If there is incomplete separation, you can get a dermal sinus tract or a limited dorsal myeloschisis, basically. A dermal sinus tract presents like this. That's a beautiful dermal sinus tract ending up in a dermoid cyst. And this is the connection that remained between this cutaneous ectoderm and the neuroectoderm. And the treatment, of course, is to identify that tract and divide it. And then there is the incomplete disjunction that produces the so-called limited dorsal myeloschisis. This is from the original article from Dackling. And there is incomplete fusion. The neural tube is still open when it separates, leading to this persistence of this cutano-neuroectodermal tract joining the cutaneous ectoderm with the neuroectoderm and having within it neural elements, unlike the dermal sinus tract that has squamous epithelium alone. And sometimes, if you're lucky and you work in a country like India, you can get two for the price of one. This is a 7-month female who came to us with 2 lesions. There's a hole on one side, there is a blue plaque on the other. So both of these are on 2 sides of the midline. Neither of them are in the midline. And of course, when you image them, you know what you're going to get. That's a diastematomyelea spur with 1 tract on the right and 1 tract on the left. And then when we go in and untether them and remove both the tracts and untether the 2 hemicords, the one on the left is a dermal sinus tract. It's got a dermoid cyst in here. The one on the right has a neuroenteric cyst in it and is a limited dorsal myeloschisis. So you can sometimes get both of them together in the same patient. So, as I said, disjunction is the 3rd stage. An incomplete disjunction can produce either a dermal sinus tract or a limited dorsal myeloschisis. What happens if you have premature disjunction, which means that the neural tube is still open, it separates from the cutaneous ectoderm? What happens then is that this bit of mesoderm decides to come and sit on that open neural tube defect, much like ice cream on an ice cream cone. So you get a neural tube which is open, covered by mesoderm, and of course, an intact skin. And that produces the so-called classical dorsal lipoma. So a premature disjunction produces the dorsal lipoma. And when we look at these patients and look at an MRI like this, what as pediatric neurosurgeons we are thinking about is not the swelling in the back, but the fact that we have a dysraphic state where the skin is intact. There is a lump which is soft to firm, not cystic, but soft to firm, the mesenchyme that has come and occupied the opening of the neural tube. And because the neural tube is open, it can lead to a neurodeficit. And that's how the embryology makes it so easy to try and understand how these things develop and how they impact the neurology of the patient. And of course, this is a disorder of premature disjunction, and this is the genesis of the so-called dorsal lipoma. The chordal, transitional, or chaotic lipomas, however, are not problems of premature disjunction, but problems of secondary neurulation. And we'll come to that in a minute. And of course, the type of lipoma, which is completely a problem of secondary neurulation, which you will recall is the chordal cell mass developing a canal and joining the bottom of the neural tube, is the lipoma of the phylum, which is only 15% of lipomas. 85% are lipomas of the conus, and this is from the original article and presentation, and these slides are from Professor Ale Pierre Khan, from his original presentation, showing a dorsal lipoma and showing a terminal lipoma, depending on its location with reference to the position of the conus. And of course, the lipomas of the conus form 85% of the lipomas. This is a transitional lipoma. To these three, Professor Pang, and this is again from his original article that he published, developed the concept of the so-called chaotic lipoma when the lipoma extends ventral to the spinal cord. So defects of neural tube closure, where there is incomplete disjunction, produces the dermal sinus tract and the limited dorsal myeloschisis. Where there is premature disjunction, it produces the dorsal lipomas. Defects of secondary neurulation produce these syndromes, the Chordal regression syndrome, the Currarino triads, and of course the secondary neurulation syndromes are often associated with hindgut urogenital abnormalities as well. The Chordal regression syndrome is completely a failure of secondary neurulation. And of course, Professor Pang has described this entity, the so-called retained medullary cord, which means that the spinal cord ends there, and then you get the phylum, and then you get a little bit of spinal cord at the bottom. Fortunately for most of us, this does not have any function. You can just simply chop it off. And the complex lipomas, as I told you a short while ago, are all defects of secondary neurulation. So if we try and recall all the closed dysraphic states, gastrulation, neural tube closure, and secondary neurulation, that's how the spinal cord forms. And if we now decide that we want to put in the dysraphic spectrum, then defects of gastrulation produce the split cord anomalies and the neuroenteric cysts. Defects of primary neurulation produce the neural tube defects. Disorders of disjunction, where it's incomplete, produces the dermal sinus tracts and LDM. Premature disjunction produces dorsal lipomas. And of course, secondary neurulation disorders produce the complex lipomas, the thickened phylums, the myelocystocele, and the chordal regression syndrome. To all this, Professor Pang has added a new concept, the so-called junctional defect disorders, which means the disorders that occur at the point where the secondary neurulation or the secondary neural tube, which is the chordal cell mass, joins the primary neural tube at its bottom. And the junctional defects are now known as the junctional neural tube defects, or JNTD. And this is one of the seminal articles that Professor Pang wrote to describe the various types of junctional neural tube defects. In the interest of time, I'm not going to go into the details of this, but you could read this very easily. But this is from that publication. And again, you can see the fact that all the problems occur at the junction of the bottom of the primary neural tube and the top of the chordal cell mass. Of course, we now know, as Professor Fegan showed you, it's not as simple as this. And the development of the spinal cord simply in the craniocaudal and its dorsoventral differentiation depends on a whole lot of factors. And if you simply look at the dorsoventral patterning of the spinal cord development, You know, it's a balance between SHH and BMP. And I'm not going to go into the molecular genetics of this, but simply to tell you that it is not as simple and simplistic as we described embryologically. So the principles of surgery, and I'm not going to go into the details in the interest of time, is to understand the anatomy, to make sure that you untether the cord. If the phylum terminale is producing a tethering component, it needs to be divided. In closed dysraphic surgery, we would always advocate using intraoperative neuromonitoring. And finally, you close to ensure you do not have a CSF leak. So in summary, to our simplistic understanding, the dysraphic states are best understood from an embryological perspective. Each can be associated with neurological dysfunction through a variety of mechanisms, but this scheme, which we think presents a unifying classification of these disorders based on the simple understanding of the basic stages of development of the spinal cord in human beings. Thank you very much for your attention, and I'll be very happy to answer questions.
Thank you, Sandeep, for this nice presentation. Any comments?
Yes, I believe Jose Salazar from Ecuador has a question. Go ahead, Jorge.
Hello. Thank you very much, Dr. Sandeep, for your excellent lecture. I have a question. How about the surgical correction of this defect before birth? What are your key points regarding this situation?
Well, the closed dystrophic states have not yet been treated with prenatal surgery. We've just had prenatal surgery limited to the open neural tube defects. So I guess there is no experience that I can draw on. The other thing is, of course, that most of these, with the sole exception of the dermal sinus tract, do not require a surgery immediately after birth. So for example, if you have a lipoma and it's symptomatic, but the neurology is not progressive, you can certainly wait for the child to be 3 months old. So I think it's a little bit different from the open neural tube defect concept, where you try and operate early, prevent hydrocephalus, prevent the Chiari malformation, and try and get to that early.
Thanks. Thanks.
Sandeep, if I may. I'm sorry.
You have comments?
If I may, this is Moody.
Please, Moody.
Yeah, Sandeep, if I remember from one of your slides, the closed ones don't seem to be caused by a deficiency of folates. Is that correct?
Yes,
why do
absolutely.
And why
absolutely.
do you think? Yeah. So, is there an why do you think that is the case? That it doesn't play a role?
Well, I think Graham answered the question. The actual contribution of folate is to work at the level of the so-called hinge cells, which basically contribute to the two neural folds getting angulated towards each other and then leading to the closure. So neural tube closure is what is dependent on folate. The other things like gastrulation, like disjunction, or like secondary neurulation are not controlled by folic acid at all. This is something that we before believed that folate stops all of this. Actually, putting folate in the diet only stops the open neural tube defects. It does nothing to the incidence of secondary neural tube defects. Sorry, the closed neural tube defects.
So there'll be other causes such as perhaps...
Most of them are genetic. Almost all, as I indicated on that slide, almost all of them, the causes are genetic. And we've been able to now identify some of them. For example, disjunction we now know is caused by imbalance, as I showed you, and I just referred to this because that's a whole talk. Imbalance between the SHH and the BMP factors that contribute to the dorsoventral development of the cord.
Right. So perhaps the incidence is higher when there is intermarriage between family cousins and things like that, rather than.
Yeah, you may be right. You may be right. I don't think we have data yet to tell us this, but I agree with you. You may be absolutely right on that.
Thank you.
Graham, I think you have a comment. Graham still here? Yeah.
It's
Yes,
not midnight for him yet.
Yeah, so Sandeep, thank you very much. That really was just fabulous. And you simplify this very complex embryology in a way that makes it so accessible. So thank you very much. And I'm looking forward to seeing that classification system. So just a couple of comments. So firstly, maybe a silly question, but it's kind of weird that the vast majority of the central nervous system develops by primary neurulation, and then just the most caudal tip of the spinal cord develops by this completely different process of secondary neurulation. And I've never really seen a compelling explanation for why that is. I don't know if you have any thoughts about that after delving deeply into the embryology. And then just maybe more from a clinical point of view, given the fact that many of the people in this webinar would not necessarily have easy access to intraoperative neurophysiology. A lot of the surgery, when it comes to more complex forms of closed dysraphism, certainly in centers like yours and mine, are very much guided by intraoperative neurophysiology. So do you have any thoughts about how people should approach cases like this if they don't have intraoperative neurophysiology, and maybe link to that the question of whether what the clinical indications are? So patients who are asymptomatic, whether one should be embarking on surgery just because there's a bit like the Himalayas. Do you climb the Himalayas just because they're there, or do you have to have a reason? And then finally, you spoke about understanding the anatomy, and I think for me the single most important point to stress is you understand the anatomy by starting with normal. And I think that the biggest disasters with these kind of cases are when you dive into the pathologically abnormal part of the malformation, get completely lost, and then you don't know where in goodness name you are. So just to summarize, any thoughts about this crazy embryological thing about primary and secondary neurulation, indications for surgery, and particularly for people who don't have access to intraoperative neurophysiology, and then maybe specific comments about the surgical technique?
Yeah, I'll take your questions from the last one first. I think you've answered the question, what do you do if you don't have intraoperative neuromonitoring? I think the key is to understand the anatomy. And to my mind, the key to understanding the anatomy is to understand the embryology. If you understand the embryology, then you understand the anatomy. If you don't understand the embryology, it is impossible to work out the anatomy. So if you, for example, deal with something like an LDM, and if you remember Dackling's article, he's got these, 5 different classifications of LDM, each with subsections and subclassifications. That's fantastic from a descriptive point of view, but from a practical point of view, if you have a lump in the back which has a normal skin cover, we used to call these closed meningomyelocele in the days gone by when life was simple and Dackling hadn't started writing all these things. Today, if you get a lump in the back which looks like a meningomyelocele, but the skin is intact, that can never be a neural tube defect, because by definition, it cannot have a normal cutaneous ectoderm. So if your skin is intact, then it's got to be either a limited dorsal myeloschisis or something like a neuroenteric cyst if it's a cystic lesion. So, the point is that if it is an LDM, you know that your basic aim is to identify the connection between the skin and the neural tube below, and to divide that connection. So the anatomy, I think, is really the guide if you don't have intraoperative neuromonitoring. I do think it's very, very useful, but if you don't have it, understanding the anatomy through the embryology, I think is really something that we've been trying to emphasize, that the embryology should not be a method of making this more complex than it already is. It should be a method to make us understand the basic anatomy so that we can work on it. Second thing that you asked about prophylactic surgery. Well, of course, to my mind, one of the closed conditions, closed dysraphic states where I would always offer surgery is, of course, a dermal sinus tract. There is no controversy about that, because every one of them, if you leave it behind, will have an infection. The prophylactic surgery, when would we offer? We would offer prophylactic surgery to, I personally think I would offer prophylactic surgery to every split cord malformation type 1. With the type 2, I have to say there's a lot of controversy, but in my own experience, I would wait and watch for the type 2 split cord malformation. These are much more difficult to do, particularly without intraoperative monitoring. I would never touch a type 2 prophylactically unless it produces symptoms. I'm not going to go into the lipoma debate, but I think most of us would now offer prophylactic surgery in dorsal lipomas as well. Perhaps not in transition, certainly not in chaotic lipomas, where we could make things a lot worse than they are. The question about embryology of the caudal cell mass. I think the real key here is that the caudal cell mass is a very compact bunch of cells put together. And the problems that occur, as we've understood now, is in fact, more problems occur at the junctional zone. And the junctional zone problems occur because the so-called caudal cell mass develops a secondary neural tube, which goes and joins the bottom of the primary neural tube. But one of the first examples of programmed cell death or apoptosis that occurs in the embryo occurs at the top of that secondary neural tube, which joins the bottom of the primary neural tube with these two canals uniting to form one canal. And I think the problem occurs because this little bunch of cells of the caudal cell mass, if you think of it, innervate so much. They innervate the sphincters, they innervate the bladder, the anal sphincter, they innervate the lower limbs, because that produces the conus. Yep. So I think that's really why we get so many more problems from the secondary cell mass and the junctional zone compared to the primary neural tube. I don't know whether I've answered your questions. These are just random thoughts.
Thanks, Sandeep. No, that's very compelling. Thank you.
Yeah, Llewellyn, you still here?
Yeah.
So,
no, look, I think
you want to wrap up? Yeah.
Sure. Look, thanks, Mo, and thanks, John. I think we haven't sort of made that point. Thanks, John, for all the logistic efforts in distribution and putting together, all of these. John, do we have any comments, by the way, that you want to highlight from the chat session?
Well, did you look through there's a couple of chat comments.
Yeah.
Okay, well, these are kind of general questions. I wonder if you could go through them, Llewellyn, to kind of prioritize them.
Yeah, so look, thanks, John. I've been through them. A lot of them are just comments, and I think in the interest of time and consideration really for Sandeep more than anyone else, I think we'll start to wrap things up. So really thank you to all our speakers. Thanks to Girish. Girish, any comments quickly, I think from your side might just give us a different perspective on these spinal dysraphisms. Maybe just a quick comment before we wrap up, Girish, if you're still around.
Yeah, Leonin, I thought, both presentations were compelling. And I thought some of the questions that were asked were quite interesting as well. One of the things I'd say, it's, of course, Graham made a very important point, why the second neurulation happened differently. I think part of it is probably because of the development of the chord equina, which is required in secondary neurulation. And that, of course, is peripheral. You could consider it as slightly different from formation of solid cord. So the caudal and sacral cord then attaches to the primary neurulation. And, Sandeep also made comments about the junctional zone and so on. One of the questions I really liked was, I think came from Niger, about the multidisciplinary management of closed dysraphism. So I think spina bifida, of course, everybody is familiar with neurological and orthopedic management of open spina bifida, and that pretty much happens with every child. But I think there is equally need for multidisciplinary care in a lot of the closed dystrophic patients as well. So the lipomyelomyingoceles often, in a way, orphaned because they don't get immediate care. They are closed, they are hidden, but they do suffer orthopedic urological problems, which are often unknown or not diagnosed. So most of them have constipation. They go through all sorts of gastroenterology investigations and so on and so forth, until finally the penny drops and they find that the kid has a tethered cord and so on. So I think all of that requires some forethought, and perhaps the spina bifida clinics should consider more thorough treatment of closed spina bifida as well. And Graham's point about interoperative monitoring is also critically important. I think it is very helpful. I use it all the time. But before we started using the modern methods of continuous interoperative neuromonitoring, we used to use the simple sort of EMG machine to use the probe to identify which were the nerves that, or where was the fatty phylum. So I think even in a basic sort of environment, it could do some form of monitoring. And it doesn't have to be very complex or very, extensive. And it may be sort of, based on what you need for that particular procedure. So I'm going to stop here now. And then fantastic meeting. Thank you very much for inviting me.
No, thanks, Girish. I think those thoughts really round things off beautifully. So it gives us a sort of a more